Hi, everyone. This is physical assessment or transition. Please understand while some of this may be very basic to you because you're doing assessments, not everyone in the class is doing assessments. Some people do not work in long-term care. Some people work in other areas where they don't do the physical assessment. I'm going to go through this. Then in lab, we will do the physical assessment. Now, your physical assessment lab is after exam 2. Understand that the content here is on the exam. The content in the skills testing will focus on, the skills lab will focus on the skills testing. Physical assessment. Why do we do a physical assessment? We want to obtain a baseline data so we know what we're doing. Components of the complete health history. You want the biographical data, that is your marital status, your sex, your religion, your occupation. All those things are really important when we're looking at discharge planning. We always start discharge planning at admission. Reason for seeking healthcare, history of present illness. You will also hear it as a chief complaint. It is what the patient says. If the patient says they are nauseous and they're vomiting, that is their chief complaint. Then once we do some diagnostics, then we determine maybe they have appendicitis. Reason for seeking healthcare is going to be in the words of the patient or the client. Past medical family history. Have they been in the hospital for this problem before, or do they have any other comorbidities? Also with the family history, we want to look at anything related to why they're seeking healthcare. And then we're going to do a review of the systems, the actual physical assessment. Assessment, the nurse judges the client's health illness status. We are going to collect data. We're going to do the nursing process. We're going to assess someone, and that's where we're going to collect the data. The data is subjective and objective. Subjective is what the subject says. Objective is what we observe. We're going to compare data with norms. Now, not everybody falls in the normal category with certain things, excuse me. We want to ask their baseline. What are their normal vital signs? What are their normal things? And then we're going to analyze those findings. We are not doing the nursing diagnosis anymore, but we still are going to create a care plan for them. We're going to create a care plan by looking at what is their active problem. And we're going to use what is called the clinical judgment model to focus on getting them better. They have a problem. We have to create a goal to fix the problem. And we may not be able to fix the problem, but maybe work toward a healthy quality of life. We are either going to do a complete head-to-toe assessment or even a modified assessment. There's tons of different ways to do assessments. When we think of a brand new admission, that is that complete admission assessment, which as an LPN, on paper, you don't do by yourself. You probably do it, and then the RN maybe signs off on that. But what you're doing is a lot of times is those modified assessments. In the hospital and long-term care, you're not doing a true full head-to-toe assessment. Then even when we do a head-to-toe assessment, we still don't do everything that you're supposed to do. And I'll explain that when I get into the actual systems. The purpose is to establish frame of reference, that baseline data, aids in early identification of health alterations, and thus early treatment. Our goal, healthy treatment. We want better outcomes for our patients, keep them, figure out what's going on, treat them, get them back home, or get them back wherever they were. Focusing on that primary, secondary, and tertiary care. If we know they have a problem, we're in that secondary prevention, and we want to focus on reducing exacerbations. We're going to evaluate those outcomes that we're going to create for them. We're going to create an outcome, and we have to do interventions to help them meet that outcome. We're going to evaluate that. And it's a head-to-toe evaluation process, but that does not mean you have to do head-to-toe. You might find that you're going to start with the problem. Maybe they're in pain. I'm not going to be able to do a full head to toe assessment if they're in pain, if I don't address the pain. If they're having shortness of breath, I may focus on their respiratory system and then let them settle down. The assessment does not need to be completed in one session. It needs to be completed within a time frame. But if your patient's short of breath, or your patient's in pain, or if your patient's having chest pain, that becomes the priority, not the head to toe assessment. The general interview, that is the questions. We want to ask open-ended questions. That way we get more answers. Introduce yourself to the patient, ask for complaints. How are you feeling? This is that working relationship that you're going to build with them, and that you're going to establish that relationship by establishing rapport with your patients. Do you have any pain or discomfort? If they have pain, we need to address the pain. If that's why they're there, that's what we need to address first. You're not really going to get much out of them if you're not empathetic to their needs. What systems does the chief complaint affect? Are they having chest pains? Well, then I'm going to do cardiovascular and respiratory. Now we use the concepts of perfusion and gas exchange, but we want to focus on that. Again, I don't have to do the full head to toe assessment all within one sitting. I might break it up. I might do the interview, might get them some pain meds, and then come back and do some more. The complete health history is also called a comprehensive assessment. Episodic, which means I'm only assessing why they're there. They had an episode. Maybe you have a patient that's been admitted for a day. They had their initial admission assessment, and now all of a sudden they're having chest pains. My assessment changes to just focusing on the chest pains. Why are they having the chest pains? I'm going to assess whatever falls within that current situation. Interval, follow-up, health history, this documents progression. As a nurse, we have to document whether or not they are progressing or declining. That is what helps with the insurance companies. Emergency health history, this assessments, your ER assessment, you're getting essentials from the patient if they're conscious. Otherwise, we're going to seek other information later. Maybe they're coming in, maybe they're having a stroke and they can't answer questions. I can get a little bit from the family. I can pull the old chart and really look at, is this something new? Your reason for seeking healthcare, their chief complaint is what they say. It's not going to be a medical diagnosis. It's going to be something, layman's terms in most cases, unless it's something they've been dealing with before. History of present illness. I use this acronym for history of present illness as well as pain. So some of the things don't really work, but P is provoking factors. What were you doing when it started? Are you short of breath? Were you exercising? Were you running? Were you just sitting there? Any quality, their work of breathing, if it's respiratory, if it's pain, this would be, is it stabbing, throbbing, anything like that? The region that it's affecting, or is it radiating anywhere? Are they dealing with pain in their chest and it's radiating down their arm? Severity will be your pain rating on a 0 to 10 scale. If they're unable to rate with the numeric, we can use the FACES, the Wong-Baker, or even FLAC, which is one for the babies, which is face, legs, arms, crying, and consolability. We'll talk more about that later. And then timing, how long has it been going on? In certain situations, some of the diseases, diagnosis, we have to treat within a certain amount of time with certain treatments. For example, a stroke, we only have a certain amount of time to give a specific medication. If they're outside that window, the treatment changes. We need to know, when did it start? And we want them to be honest with us. If it's been going on for 1 week, please tell me it's been going on for 1 week. I'm still going to care for you the best I can, but some of the treatments in certain situations could be life-threatening if we give it outside of a time frame. And then understanding, what do they understand about this illness, this disease, this episode? Have they had it before? And then it kind of goes back to the P again. Well, what did you do to make it better? What did you do to make it worse? Education and occupation, it's important to know if most of our medical educational pamphlets are set at an 8th grade reading level. If they are higher than that, we can have conversations a little higher than that. But if they're a doctor, it doesn't mean they're a medical doctor. So you don't want to assume that they understand the medical language. Occupation, as I mentioned, it's important to know that, because if they are going back to work, maybe this illness is going to prevent them from doing their job. Maybe they can't drive anymore. Maybe they were diagnosed with something where they can't drive anymore. What if they're the breadwinner? We want to start addressing that early enough. That way we can support them and solicit help, care, case management, social work, any resources, support groups, anything like that. And then their living environment. Joint Commission requires us to ask certain questions. Some things along the line of, are there stairs in the home? And this is a good question because, again, we want to plan discharge at admission. If they have 10 steps to get in the home and they just fractured their hip, they may not be going right home. They may have to do a rehab. What about a bathroom on the first floor or the floor they're going to be on? Are they going to be able to get their meals? Are they going to be able to open their pill bottles? Are they safe at home? Another thing we have to address is domestic abuse. Are they suicidal, homicidal? And then is there any drug use? Allergies. We don't just ask, do you have allergies? Because people will say, yep, I have allergies. We want to know what the allergy is and how it affects them. If somebody says I'm allergic to Tylenol, it makes my stomach upset. Okay, that's not an adverse effect, that's a side effect. We can manage that. Current medications, including over-the-counter, anything that is not prescribed as well. Non-traditional remedies, are they using herbs, anything like that? And I always present this as, I'm not going to judge you in any way, but I need to know, because some of our treatments don't go well with over-the-counter meds or some of the non-traditional remedies. I want to make sure I am providing the best care for you. Please let me know what you take. Family history, we talked about current living situation and ability to care for self. And again, history of smoking, drug, and alcohol use. If they told you they smoke, they use drugs, or so alcohol use, you want to ask them the last time they had one, because the worst thing in the world is they have an illness and then you add withdrawal on top of that. We do want to ask them. I tell them I'm not the police. I'm not going to do anything with the information except treat them. But if they are a drug, a substance abuse user or alcohol abuser, we want to make sure we're aware of that in the event they do start to withdraw. Past medical history. Now, if they've been in the system before, a lot of this information will be there. But if they're jumping from hospital to hospital, or they just recently moved to the area, that comprehensive assessment takes a little bit longer. If they've been there, it doesn't take as long. But we want to know about childhood illnesses, accidents, vaccine records, serious illnesses, hospitalization, family history. Now, do I need to know every time they stub their toe? No. But do I need to know that if they had a respiratory illness as a child that had them in the hospital for weeks? Yes, that's going to be important. You're really going to focus on why they're there. Lifestyle and functional assessment. You have self-esteem, self-concept, activity, and rest. Are they going to be able to continue their normal lifestyles? We want to focus on activities of daily living, and we also want to focus on IADLs. We want to know about their sleep habits. Do they sleep so many hours at night? Do they use many pillows? You know, in the hospital, pillows are like gold. You can never find it. You're lucky if you get one, but if somebody requires multiple pillows to sleep, we want to try to accommodate that. Nutrition elimination, when we get into each system, we'll talk about what questions you ask. Relationships, coping and stress management, personal habits, environmental hazards, Again, knowing their occupation is going to be important. And then because depending on what the problem is and what they're going back to. I'm sure most of you know what ADLs are. That's your personal hygiene, different things like that. Then you have your IADLs, which is instrumental activities of daily living. These are more cognitive. This is something like answering the phone. Most people have gone to the smartphone, but are they able to answer it? Are they able to dial the phone? Are they able to open up the pill bottles? And I said this says jars, but think about it. Are they going to be able to care for themselves and do these little things that will help them? Ability to wash self, can they feed themselves? Can they dress themselves? If not, if you get a no to any of these, get physical therapy and or occupational involved as soon as possible. Skills for assessment, you should all know this. Now, are we going to spend a lot of time on palpation and percussion? No. We will do some palpation, but not to an extreme. Inspection and auscultation are going to be the lifeline of this assessment. When we're doing inspection, we're looking, we're comparing left to right, we're comparing color. Is the color appropriate for ethnicity? We're looking to see if they're breathing, what's their work of breathing? As we get into each system, we'll go a little bit more detail. And you always want to compare one side to the other. Look at the whole person and each body system, compare right to left to right, color. What you need is good lighting. You want to make sure your patient is comfortable. If they're in pain, yes, you'll probably be able to look at them, but you're probably not going to get much out of them. So we want to address that. Auscultation, you all should know how to use a stethoscope. If you don't, come see me. I'll show you how to use it properly. But the stethoscope is what you need to listen to your patient. Percussion, again, you're not really doing percussion on a day-to-day basis. So these are just the sounds. I will tell you anything in this PowerPoint is fair game to the exam. So you have timpani, which is a high pitch, loud intensity. This is like cheek filled with air or air in the abdomen. So if you're percussing, you're listening for that high pitch, loud intensity. Resonance is low pitch. This is like normal lung tissue. Hyperresonance is higher than resonance. It's very loud. This is trapped air. If you're trying to determine if they have trapped air versus normal air, we don't have air in our abdomen. We don't have air in our lung cavity. It's inside the lung. So some of those sounds, if you're doing percussion, you would hear. You're not going to do percussion over a bone. You want to make sure that you're over a tissue. Flatness, this would be a sound that you would hear if you were over a bone, like the sternum. Dullness would be over kidney or lungs or even a consolidated lung. So it's like muffled. Palpation, now we do palpation. We do light palpation, deep palpation. This is something as simple as putting your hand on them and feeling color. Texture, temperature, moisture, organ location and size, swelling, vibration, pulsation, rigid or spasticity, crepidation, presence of lumps or masses, and presence of tenderness or pain. We want to palpate the most painful last, because if you start pushing on something, you're going to cause more pain, which they probably will make you stop. You want to try to do the palpation last to the area that's most sensitive. Use your fingertips, grasp of thumb and fingers, back of hand, base of fingers. You have light palpation to deep palpation. If you are palpating the abdomen, we're going to talk about the GI system because it's a little different of the order, but you're going to do a light palpation and then you're going to do a deep palpation. Now into head to toe, head and neck, you want to assess the scalp. Now, do we go in there and check their hair and all that stuff? No, unless that's what they're in for. Now, if they're coming in complaining of head lice or dandruff or anything like that, then yes, I'm looking detail. I'm also looking detail if they're malnourished and they have wounds all over them. I want to make sure there's no wounds in any areas like bony prominences, which would be the back of the head if they're laying on their back all the time. Assessment of the neck. Goiter is one of those areas that you can palpate. I mean, the thyroid, not the goiter. The thyroid is something you can palpate, and you're also assessing for lymph nodes in the throat. If they're complaining of sore throat, that's the first thing that we usually check is for any lymph node involvement. When you're assessing carotid artery, so assessing lymph nodes is different because you're just kind of pushing, but when you're assessing carotid artery, please only do one side at a time. If you do both sides at the same time, you will make them lightheaded and possibly pass out. One side. Cognition, the concept of cognition, the ability to think, learn, reason, perceive, and remember. When we're doing a neurological assessment, we want to assess for level of alertness, level of consciousness. So you'll see LOC, level of consciousness. Are they alert? Are they lethargic? Are they stuporous? Are they in a coma? Are they able to answer your questions appropriately? When you ask them a question, do they answer appropriately, inappropriately, incomprehensible, or no response at all? Do they understand? Can they follow commands? When you're going through the list of neuro, think about anytime the brain is affected, the brain is sending the signal everywhere. If they cannot comprehend, is it because they've had a stroke? Or do they have a traumatic brain injury? Or are they having other issues like a urinary tract infection or even altered glucose levels? So we want to make sure we're assessing. Level of consciousness is one of those things that will change drastically. And that's usually our first indication something's wrong. Orientation, are they alert and oriented times 1, 2, 3, or 4? Some places use 4. Most people understand the person, place, time, but they may not understand why they're in the hospital. That's why some institutions added the 4. That way we could just address that. Reorienting them is going to be important. Are they disoriented? Are they confused? Do they have sundowners? Those of you that work evenings, I'm sure you've experienced sundowners with patients. Stuporous is unconscious, no spontaneous movement. And then the concept of neural regulation, the processes by which the nervous system activates, coordinates, and controls the function of the body. When we do a neurological exam, in addition to assessing whether their level of consciousness, alert and oriented, we also want to look at their appearance, their behavior, their cognition, and thought process. Appearance. What's their posture like? You know, we all have horrible posture, but is it appropriate? Body movements, is it appropriate? Dress, is it appropriate for the situation? You know, if it's 100 degrees outside and they're wearing, you know, a snowsuit, is that appropriate? Now we know the older population tends to be colder, but a sweater, you want to dress in layers. Grooming and hygiene, are they able to perform themselves? Do they need assistance? And if they're able to do themselves, can they do it adequately? Behavior goes back to the level of consciousness, alert, lethargic, delirium, which we'll talk about, stupor, or coma. What facial expressions, do they match what is going on? Speech, mood, and affect. Is their affect appropriate? If I just told you your best friend ran away, are you laughing? Are you crying? Is the mood congruent with the situation? Facial expressions with Parkinson's, they usually have the mask-like face. So we want to assess that if they have Parkinson's or even if they're on meds that could cause Parkinsonism. Cognitive function, their orientation. Now, in most cases for normal assessments, we are not doing a mini mental exam unless that's why they're there. We're not going to give them words. Oh, here's 3 words, repeat them and repeat them back to me. Most of the time I forget them. unless I'm doing a detailed neuro exam. Now, where you work, you may have a checklist of what you have to ask, but it's not really something. I may say, hey, what did you have for lunch? But if it's 9 o'clock in the morning, that doesn't work well. So you have to think about that too. When you're asking time and place, make sure you understand. I will never ask somebody what day it is because I never know what day it is. I work nights a lot of time without sleeping. I have no clue what day it is most of the time. So I'll do either a season or what holiday. So you just want to tailor to what you're working with, what population you're working with. What's their judgment like? If you tell them to use the call bell before they get up and you go back in the room and they're walking back from the bathroom, you have to reassess them, reorient them to use that call bell. Thought process and perception. What is their thought content? How do they perceive things? People perceive things very different. Assess them for suicidal or homicidal ideation. We'll talk about that more detail when we get to mental health. And then that mini mental state exam, again, we'll talk more about that when we get to mental health. Glasgow Coma Scale, we should be using this. You should know this by heart. Eye-opening, verbal response, and best motor response. The lowest number is 3, highest number is 15. 12 to 15 is a good Glasgow Coma Scale. Anything less than that, there is neurological defects. So we want to address that. Other complications with neuro, they'll have what's called decorticate or decelerate. Decorticate, their arms curve in toward their core. Decelerate, they accelerate away from the body. These are due to brain injuries, and they'll either decorticate, and you'll see them literally like their arms will kind of curl in toward their core, or decelerate, which would be accelerate away from the body. Pupillary response, when we do PERLA, PERLA is pupils equal, round, reactive to light and accommodation. When we do PERLA, you have to be able to look at both eyes. So you have to shine the light multiple times in each eye. PERLA is also accommodation, which is you take the pen, pencil, finger, or whatever, and have them follow it to their nose. Basically, their eyes should converge in. The 6 rules of cardinal gaze assesses the visual fields. That is separate from PERLA. The PERLA literally is shining the light in the eyes, making sure both eyes are equal, round, reactive to light, and then you take it and bring it in toward the nose, and that is checking for accommodation. Assessing the visual fields, you want them to follow your finger. You do 6 points. So it's this rules of 6 rules of cardinal gaze. The other thing would be like Snellen charts when we get into vision. Assess hand, grasp, and leg strength. As you see during the assessment, we're kind of hitting a couple different things at the same time. If you do it once, you don't have to go back and do it again. So right now, if I'm having them grab my hands, I'm checking neurological as well as musculoskeletal. If they're walking or anything like that, I'm assessing their gait. You don't have to go back and do it again just because it's in 2 separate systems. You would just document the finding in each system. And depending on where you work, most places are charting by exception, or you would only document what's abnormal. And then you would fill in the blanks with your progress notes. Reflexes, we have our deep tendon reflexes. We want them to be 2. 0 is absent, 4 is hyperactive. If you have deep tendon reflexes, you can have increased or decreased. There's a problem there, and we have to address that. Eyes, you should have 2 eyes. As far as what part of the eye, it's important to understand the iris, the sclera, the lower lid, but don't get so focused on like so much of the anatomy and physiology. In most cases, we're past that point. You need to know more so of how to care for someone if there's a problem. But when we do eyes, we're looking, is it symmetrical? Do they have any drainage? Do they wear glasses? Do they wear contacts? Do they have strabismus? If you're working in an ENT office or an occupational health clinic, this is where you're going to do more so the ophthalmoscope, the vision screening. We don't do it on a day-to-day unless that's what they come in for. If they come in for vision problems, then yes, but it's not part of that day-to-day assessment. Do they have a prosthesis? If they do they know how to care for it properly? Excuse me. Inspect the external eye structures. You're looking at their eye overall. Do they have the lashes, the eyebrows, the eyelids, the eyeball alignment? We also want to look at the conjunctiva and the sclera. Our conjunctiva and sclera should be moist. The sclera should be white. There are going to be times it's different colors based on disabilities and certain diagnosis. The lacrimal duct, when we give eye drops, we want to place the eye drop in the conjunctival sac, but we want to hold the lacrimal duct so it doesn't drain down into the throat. Snellen chart, if you have someone that can't read letters, like a smaller child, there's also pictures. Near vision, that's, I always joke, for the longest time I didn't need glasses. Now I need glasses because I can't read anything. I always say my arms are shorter, so I have to hold it further away. Presbyopia is a decrease in accommodation, so that's arms aren't long enough. And then the different types of testing. Again, this isn't going to be something we do on a day-to-day assessment. This is going to be if you work at like an occupational health or like doing vision screenings or hearing screenings. Looking at the eye, the cornea, the lens, the iris and the pupil, looking size, shape, make sure it's equal, and then corolla, pupils equal, round, reactive to light and accommodation. Meiosis is constricted and fixed pupils. This usually is caused by brain damage or even narcotics. They literally have little pinpoint pupils and they do not react. Mydriasis is dilated and fixed pupils. This is usually because of deep anesthesia, circulatory collapse, or nervous system injury. So you'll see this big pupil, but it won't react. Most pupils get big or small, depending on the light. So when you shine the light, they don't move, which looks crazy when they don't respond. Accommodation, this is, again, you want to bring that finger, that pen, whatever, in toward their nose, and then they should follow it and should look, the pupils constrict and the eyes converge. Ophthalmoscope, you should encourage your patients to have their eyes checked yearly because optometrists can really see a lot. If they have comorbidities, they can see if they have any interocular eye pressure. So they can, you really want to encourage people getting their eyes checked yearly. Again, this isn't something we do on a regular basis unless you work in the clinic. Ear, looking at the ears, do they have both ears or the structures intact? Are they symmetrical? Looking at any drainage, do they have any hearing loss? If they do, is it, are they still able to hear? When someone is hearing loss, you don't have to yell at them. A lot of times just talking to them face to face is sufficient. I never realized how much I rely on reading lips until COVID. When we put the mask on, I'm like, what, all the time. I'm also that type of person that has to turn down the radio when I'm looking for a street sign. I don't know why. I think it's the weirdest thing. And I know I do it, but I have to. But I think it's because I need to concentrate if I'm looking for a street or something. So the ear, position, alignment, note any lumps, bumps, bruises. If you have someone on oxygen, make sure you're checking the skin behind the ear because that tubing can really break down that skin. Evaluate for any tenderness, any drainage. This is otitis externa, which is swimmer's ear. So this is infection of the outside or inflammation of the outside ear, the external part of the ear. Frostbite, Again, looking at the skin is going to be really important. Ears, are they hard of hearing? If so, which ear? If they're hard of hearing, do they use assistive devices? And do they work? Do they have a battery in them? Otoscope, you want to make sure that if you are looking in their ears, you're not sticking it any more than a ½ inch. You're looking for any wax, any swelling. You don't want to aggravate the tympanic membrane. The tympanic membrane, when is normal, it is a translucent, shiny pearl gray. When it is red or bulging, that means it's infected. And there's different layers of the infection. It could be just inflamed versus infected. Otoscope, you're going to look at the external canal. We're not sticking it so deep down in the ear. We literally just want to look at the middle ear, but you're not sticking it at more than a ½ inch. So this is what tympanic membrane should look like. No infection, no inflammation. It's a little inflamed. This one's a lot inflamed, and this one's infected. Testing and hearing acuity. If you're working in a clinic or occupational health, you're doing this more so. Note behavioral response to conversational speech. You can do the voice test, the tuning forks, that's the Rhine and Weber. Take the tuning fork and you bang it. You sit it on the top of the head and then behind the ear. They should hear it as well as feel it. That's the whole point of assessing that. Nose, inspect the nose, palpate the nose, look for any deviated septums, ask them to hold one nose and breathe in, determine if there is a better side. In the event we have to put a tube down their nose, we want to put it in the side they don't use as much. Looking at do they have any nasal discharge? Looking at, is it moist? Palpate the sinus area. You know that the sinus area is not just around the nose, it's around the cheeks and the forehead. So assess for drainage, redness, tenderness, or even a deviated septum. Ask them if they have any problems breathing through their nose. Mouth and throat, inspect using a pen light. Look at their teeth, look at their lips. Do they have any broken teeth, loose teeth? Do they have dentures? Is their tongue pink and moist? We want moist mucous membranes. Palpate palate and uvula. Grade tonsils, do they have tonsils? Have they had their tonsils removed? Tonsils can grow back in some cases. So you want to address that if they're complaining of sore throat. Again, if they start with the sore throat, you're going to palpate for lymph node enlargement. Palpation when indicated by manual palpation of the mouth. We don't usually do unless there's trauma. And again, that wouldn't be a general assessment. With neonate, you're going to put a gloved finger in, and then they should suck. It's the sucking reflex. Dentures, is there any swelling? Is there any bleeding? Do they have any gingivitis? Are they able to care for their mouth care by themselves, or do they need assistance? Any difficulty swallowing? Some people don't know that they have difficulty swallowing. Things that we look for would be like a silent aspiration. If they are clearing their throat a lot, if they are swallowing a lot, if they're tearing up, but they're not actually choking, those all could be signs of truly choking. We want to assess for that. If they we'll get into nutrition, but if they are having difficulty swallowing, use your resources, get speech involved. We can get a barium swallow to determine if we need to thicken their liquids. The concept of oxygenation, you're going to hear me say oxygenation and gas exchange. Oxygenation is the process that maintains oxygen levels necessary for the survival of living things. Respirations. When we listen for inspiration, expiration, which is one respiration. You're asking them questions along the line of, are you short of breath? Do you have a cough? I'm not going to tell you what questions exactly to ask, because I want you to think about it. This is what builds that critical thinking. You want to assess anything that affects the respiratory. Well, if respiratory is affected, cardiac's affected. A lot of those go together. Do they have difficulty breathing? Is it on exertion? Is it at rest? Do they have the ability to walk from point A to point B without getting short of breath? Do they require oxygen? Do they have a cough? Is it productive, non-productive? Do they have hemoptysis, which is bloody sputum? Do they smoke? If they smoke, how many packs a day? If they did smoke, how long ago did they quit? Do they have shortness of breath, dyspnea on exertion? Oxygenation, normals for adult, because we're an adult course. 12 to 20. Depth is normal. Normal is normal. But we also could have deep or shallow respirations. Are they regular or irregular? And what is their work of breathing? Are they working really hard? Do they have sternal retractions? Do they have nasal flaring? If they're working really hard, why? Is it because they just ran a marathon? Or do they have a respiratory problem? Do they tripod, which is also the orthopnic position? That's when they put their elbows on the table and they lean over. That helps open up the air, open up the cavity to expand their lungs a little bit better. Subjective symptoms, so these are what the subject says. They're short of breath, they're orthopnic, so that it would be positional breathing, nocturia, dyspnea, cough, dyspnea on exertion. We're gonna inspect, we're gonna look at their whole chest. Is it round? Is it symmetrical? Do they have what's called a barrel chest or a rigid chest cage? That would be someone that has COPD. Because what happens is as that CO2 builds up, it actually alters the anatomy of the bones. Looking, it becomes more barrel, which makes it harder for them to breathe. That is the type of patient that would have orthopnic breathing or orthopnea. Use of intercostal muscles. Intercostal muscles are the muscles in between the ribs. If they breathe in, can you see their ribs? Can you see that they're using, it's also called sternal retractions. Right side, we have 3 lobes, left side, we have 2 lobes. When we do physical assessment, I will talk about how many times you truly listen. Your book, I believe, says 10 on the front, 12 on the back. Now, if I have a person that is short of breath, there is no way I'm going to get them to breathe 22 times deep breath. What I do is I usually start at the bottom because that's where any fluid's going to collect. Now, textbook wise, you're going to start at the top and work your way down. You're going to go left to right, right to left. But again, you've got to do it based on the patient you have. Inspecting that thoracic cage, the respirations, their skin color. Skin color is related to gas exchange. If they're not getting good gas exchange, they don't have good tissue perfusion, they're going to show signs of cyanosis, which is bluish color. They might have clubbing of the nails. They may be working so hard that they're grimacing. And then if they're not getting good oxygen, they may have some changes in their mentation. So their level of consciousness may change. Percussion, we're not really going to do. In the event that you're doing it, you're looking for any trapped air. Maybe the patient has a chest tube. Now they have some crepitus, but nothing, it's not really one of those things we do on a day-to-day unless we're trying to rule out something. Auscultation, we want our normal breath sounds, normal, clear. Adventitious sounds, we have crackles or rails. Rhonchi and wheezes. I think your book says that rhonchi is also snorus wheezes, which I don't like that term. Rhonchi, the best way to describe crackles versus rhonchi. Crackles, if you know what Rice Krispies are, the Rice Krispie cereal, you pour it in a bowl, that's crackles. You pour milk in the bowl with the Rice Krispies, and that's rhonchi. Rhonchi is very wet, and it usually clears with a cough. Not all the time, but usually we can get a rhonchi to clear because it's a wet cough, where crackles is more, there's not enough fluid, so it's crackling. And then wheezes is due to an upper airway narrowing of the trachea. Again, your book, 10 on the front, 12 on the back, but the more modified is 4 on the front, 4 on the back. Well, it's really 8 and 8. Again, I want to assess. I want to be able to hit every lobe, because if I'm listening at the top and the bottom, I'm missing the middle lobe on the right side. What if that's where the problem is? Make sure that you are going left to right, right to left. Normal breath sounds. You need to know what normal breath sounds are. Your bronchial, bronchovesicular, and vesicular. So as far as what do they sound like, you have to know where they're coming from and why they sound the way they do. Your bronchial is in the trachea. So that's that more, whenever you see a doctor put the stethoscope to the neck, he's listening for the bronchial, but he's also listening for any bruits or thrills. Vesicular is actually in the lung itself. And then the bronchovesicular is at the bronchial tree right before it goes into the lungs. So it is important to know those sounds. And I did post a website that has the sounds. Please go in and listen to them just so you can identify which one is which. We're listening for the bronchovesicular sounds and the vesicular sounds. Other things respiratory assessment wise, we're going to do a pulse ox. It is the quickest non-invasive assessment, unless they have cord tissue perfusion, acrylic nails, anything like that. When you're doing the pulse ox, you want to make sure you have a good waveform. It should correlate with your heart rate. Clubbing of the nail beds, sometimes that happens because of the respiratory, the buildup of the CO2. And that's a picture of the clubbing. Cheyne-Stokes. So these are your terms: Cheyne-Stokes, Kussmaul's, and Stridor. Cheyne-Stokes is a respiratory pattern with periods of apnea. This happens a lot toward end of life or even traumatic brain injuries. They will breathe normally, then they'll have a period of apnea, which is without breathing. And then to catch up, they'll go, and then they'll have a period of apnea again. And then they'll have a period of apnea. That period of apnea may get longer and longer. Kussmaul's breathing. Kussmaul's is extreme increased rate and depth of respirations. This is usually seen in your ketoacidosis, your diabetic ketoacidosis, which we'll see a little later. Very fast, very deep. No, very fast. Sometimes it's shallow. I know it says depth of respiration, but it's shallow. And sometimes they'll have fruity breath, and that's ketosis. Stridor is a very high pitch wheezing. It's much higher than wheezing. It's like, it's like a laryngospasm, which now I'm having, and my dog's barking, I'm sorry. So when they may have a spasm or they have a foreign object obstruction, they're unable to pass any air. Cough. Do they have a cough? Is it productive, non-productive? If it's productive, what does it look like? How much do they have? Do we need to get a sputum specimen? The best time of day to get sputum specimen is first thing in the morning after it sits in their lungs all night. As far as suctioning, if someone can cough, their cough is much stronger than anything that I can do. When we get into oxygenation and do trach suctioning, they need to be able to cough to get that out of their lungs. We are not doing lung suctioning, we're doing tracheal suctioning. If someone has a non-productive cough, but it's still wet, what we can do is we can increase fluids. We can give them medications, which we'll talk about how medications to increase the cough. We can give meds to decrease the cough. We can give meds to help break up the mucus. This is a patient that has COPD. He has that barreled chest, so it looks like a barrel. It's very rigid. The concept of perfusion, the exchange of blood, gases, and fluids between the vessels and tissues and organ systems. Perfusion is one of those things. I love perfusion. I love doing all the lectures for perfusion because the heart is an amazing thing. Now, when we talk perfusion, gas exchange is still a strong component with that because you have to know the flow of the blood. When we do perfusion, we'll talk detail about the flow of the blood and why it's important. Questions that you would ask are going to go along the lines of chest pains, any numbness or tingling. We're looking at, are they having gas exchange issues as well? And then are they having edema? When we talk perfusion problems, we do congestive heart failure, we do dysrhythmias, we do myocardial infarction, infective endocarditis, DVT. Those are things we'll get more detailed when we do the exemplars. This is just what you do for your basic physical assessment. Then when you get the answers to your questions, then you go deeper. So right now we're doing the nursing process, we're doing the assessment. That way we can analyze all the data. The point of maximum intensity, most people do the apical pulse up at the top, but it's not. It's the mid-clavicular line, fifth intercostal space. So for the females, you do need to lift the breast up and you need to palpate for the PMI, and then you auscultate. You apical pulse, anytime we're giving any cardiac meds, we must listen to the apical pulse for 1 full minute. In adults, we're going to hold any med if the heart rate is less than 60. Children, it's a little higher because they have a faster heartbeat. Palpation, assess for any abnormal palpations, lifts, or thrills. If you have a pulsation in the abdomen, that is usually an indicator that they have a abdominal aortic aneurysm, which can be very deadly. Inspect color, warmth. Again, oxygenation and perfusion go together. If they're not perfusing, they're not getting oxygen. Pulses, I talked about carotid already. Don't assess both of them at the same time. Where is the carotid? Where's the apical? You need to know which ones. When I do an assessment, I go most distal. For example, if I'm going to check for peripheral pulses, I go most distal first. The reason for that is if I have a pedal pulse, I have a pulse throughout. If I don't have a pedal pulse and I can't palpate it, I do not say it's not there yet. I need to say that it's not palpable and then get the Doppler. There's no reason to go femoral, then popliteal, then posterior tibial, go right to pedal pulse because it is the most distal. Same thing with the arm, I'm going radial. If I have a radial pulse, I have a pulse throughout the arm. Cap refill, I'm going to that longest digit. For me, happens to be my middle finger and my big toe. When you're assessing your patient, really look at them. Everyone's different. That's why we individualize care. Inspect and palpate, describe location of any of the apical impulse. Again, mid-clavicular line, fifth intercostal space. Auscultation, when you auscultate, you may know different ones, but I learned all people enjoy Time magazine. Aortic, pulmonic, herbs, tricuspid, and mitral. All people enjoy Time magazine. Some people have learned Apartment M. Herbs point's not really one we really listen to. Your aortic is your second intercostal space on the right. Pulmonic is your second intercostal space on the left. The third intercostal space would be herbs. Then fourth is tricuspid. And then fifth will be your mitral or apical. You will need to know what's happening when the aortic, pulmonic, tricuspid, and mitral valve open and close, open and close, open and close. You need to know that. So again, all people enjoy Time magazine. Yes, I'm a visual person, so I like to show lots of pictures. Cardiovascular assessment, S1, S2 is normal. That's your lub-dub, lub-dub, lub-dub. S1 is when the mitral and the tricuspid open and close. S2 is when the aortic pulmonic open and closes. S3 can be normal up to the age of 30, but it also could indicate congestive heart failure. S3 is heard after S2, so you would hear lub dub dub, lub dub dub, lub dub dub. S4 is a murmur, a click, could be hypertension, ventricular hypertrophy, or myocardial infarction, and that's heard before S1. So it'd be lub lub dub, lub lub dub, lub lub dub. Then you could have murmurs or clicks. If you have someone that has had a mitral valve replacement, if they had a cadaver, meaning it's the same tissue, cow tissue, pig tissue, anything like that, it's not going to click. But if it is mechanical, it will click. You can actually hear it without a stethoscope. It's pretty cool when you hear a click. Murmurs are graded. We're not going to get into like grading them because you're not going to be a cardiac nurse. You may go out and be a cardiac nurse, but we're focusing on the generalist. So that just know that there are different types of murmurs and they're graded, and there's different type of clicks. Again, the lub, which is your S1, is the closure of the mitral and the tricuspid valves, best heard over the apex, and it does correspond to the carotid pulse. S2 is the closure of the aortic and pulmonic valves, and best heard at the base of the heart border. S3 is because of rapid blood flow, can be normal up to the age of 30. Otherwise, it would be like your congestive heart failure, and that's heard after S2. S4 is heard before S1, and that is because there's ventricular stress, hypertension, ventricular hypertrophy, or myocardial infarction. The ventricular side is stress, so it's causing a heart to beat a little bit more. Murmurs, again, there are different grades, but what you have to know is conditions. There's velocity and blood increases, viscosity of blood decreases, structural defects in the valves when we talk about infective endocarditis, unusual openings in the chambers. When you get into peds, you'll talk about the different heart defects in utero as well as when the baby's born. But the murmurs are like swishing sounds, and a lot of people miss murmurs. At this point, the idea is that you're able to recognize something is wrong, but you may not understand what is wrong. It takes years to really, truly be able to identify the murmurs. Jugular vein distension, the only way you can assess that is if your patient is laying down with a 30 to 45 degree angle. You're going to turn their head slightly to the left or the right, and you're going to see that jugular vein distended. Assess for any bruits or thrills. That is jugular vein distension. Again, they have to be laying down. When we do health assessment, when we do the skill, you're going to be sitting in chairs for the most part. You're not really going to be able to assess for JVD. Peripheral vascular assessment. One thing I will always say throughout this entire program is know your 5 Ps. Pain, pallor, paresthesia, pulselessness, and paralysis. Any time I do a neurovascular check, those 5 things are my key. Do they have pain? Do they have a pulse? What is their pallor? Pallor stands for color. Paresthesia, that is that numbness and tingling. And then paralysis is no movement at all. When I'm doing a peripheral vascular assessment, those 5 Ps are my assessment, as well as cap refill and pulses. I'm looking to see if there's any edema. Cap refill should be less than 2 seconds. And basically you pinch it and it should return to normal. DVT, so some of these are just pictures. DVT is part of perfusion. We'll talk more about that, but you want to assess for any DVT, know the risk factors. Laying in bed is a big risk factor for DVT. So treatment would be our SCDs and TEDs. Pitting edema, you have pitting edema and non-pitting edema. You can't have slight non-pitting edema. It either is pitting or it's not. So you can have slight edema, +1, 2, 3, or 4. You can see, when it's a +4 because you push down and it just never comes back. That's just so much fluid in the cells, not in the cells. Concept of nutrition, the intake and the use of nutrients by the body. Some of this is going to be a repeat because of the mouth. A GI assessment, GI system, gastrointestinal system starts at the mouth, ends at the anus. There's a lot that goes on in between. GI is one of the most common systems people seek healthcare for because they get nauseous. I don't know why I'm nauseous. I'm vomiting. It's one of those systems that has so many different things. Mouth and throat, we've talked about looking at with pen light, do they have teeth? Any teeth loose? Moist mucous membranes, palpation. Again, if you're doing it, not usually, with the neonate, the sucking reflex. Questions for nutrition. How's their appetite? Are they able to swallow? Do they eat certain foods? What is their diet like? We want to ask all those questions related to why they're there. If they're there and they tell us they're on a kosher diet, and we accommodate that. What if they need a puree diet versus a mechanical soft? So when we do nutrition, we'll go more detail with that. Assessment is very different for the GI system. We're going to inspect, so that stays the same, but instead of percussing or palpating next, we're going to auscultate. As soon as you start to push on the abdomen, it's going to increase peristalsis. Peristalsis is the sound that you hear. Normal bowel sounds are 5 to 30 within 1 minute. I'm going to say that again. Normal bowel sounds are 5 to 30 within 1 minute. I'll come back to that. Uvula, this is a picture of acute tonsillitis and pharyngitis. Inspect, we're going to look, symmetry. I have an idea of what's in, we break our abdomen down into quarters. You have your right upper quadrant, your right lower quadrant, left upper quadrant, left lower quadrant. So I have an idea of what's in each quadrant. Some of them overlap, and that's okay. But if a patient's complaining of right lower quadrant pain, most people know that could mean appendicitis. Left lower quadrant sometimes is diverticulitis. Left upper versus right upper. Right upper could be liver, pancreas, gallbladder, anything like that. So just have an idea what's in each area. You're going to look at the skin. You're looking to look at the abdominal girth. Is there any pulsations, any movement? If they have ascites and you push on their belly, it's going to be like a wave-like movement versus just edema. It's very different. Hair distribution throughout the body. Do they have alopecia? Sometimes with nutritional defects, they'll have patches of hair loss. Any abdomen distension or striae or scars. Scars, did they have a C-section? Did they lose a lot of weight? What's going on? So a lot of times we're asking more questions based on what you find. That's why I don't want to get so hung up on what questions do I want you to ask. I want you to ask the appropriate questions. Percussion, organs are dull, tympani, heard over air hollowed sound. Again, we want to inspect, then auscultate first, then percuss, and then palpate. Percuss all 4 quadrants, percuss borders of liver and spleen. You should be able to palpate the liver if they're laying down with deep palpation. If you're feeling a lot more than the liver, usually that's liver enlargement. Look for any masses, light palpation, all 4 quadrants, deeper, palpate, again, for liver, spleen, and kidneys. Everything's protected with the ribs, so if you're feeling too much of it, it's enlarged or something wrong. The concept of elimination, the removal of fluids and waste from the body. You have bowel elimination. What do I want to ask? When was your last bowel movement? Was it normal for you? Did you look at it? What color was it? Was it soft? Was it formed? Do they have history of constipation or diarrhea? Are they taking anything? Again, I don't want you to memorize certain questions. That's why I'm not giving you a lot of questions. I want you to think. If you have something wrong with your GI system and you're not having a bowel movement, what questions would you ask? Even if we don't eat, we should still be passing gas and passing something. Toward end of life, obviously the bowels are going to become less and less over time when they stop eating, but they still should be producing sounds. Again, bowel sounds, normal bowel sounds are 5 to 30 per quadrant per minute. You do need to listen to each quadrant. Do they have fecal impaction? Someone could still have liquid stools and have a fecal impaction. And the only treatment for that is digital disimpaction, double gloves and lubrication. You might have to do like a soap suds enema or a mineral oil enema, but most of the time you have to do digital, which means your digit needs to disimpact them. Pencil-like stools, that could mean that they have hemorrhoids, could mean there's some other complications going on. Auscultation, less than 5 per minute is hypoactive, greater than 30 is hyperactive. This is per minute. 5 to 30 is normal per minute per quadrant. For you to listen to bowel sounds, you should start in the right lower quadrant, right upper quadrant, left upper, left lower. That's the way the colon goes. You have your ascending, your transverse, your descending. So you want to follow that when you're listening. If you get to a quadrant and you don't hear bowel sounds within 1 minute, you stay there for 5 minutes. You cannot declare they have no bowel sounds until you listen for 5 minutes per quadrant. That's 20 minutes that you could be standing there. So do not like jump this one. Do you have to stand there for a full minute each quadrant? No, as you get experience, you're gonna know what hypoactive is, what hyperactive is. You're gonna know. You're also gonna look for any distension. Are they bloated? Do they feel constipated? Again, know what's in each quadrant. Some overlap, that's okay. But here's just a kind of picture your ascending colon, your transverse colon, and then your descending colon. That's why we listen right lower quadrant, right upper quadrant, left upper, left lower. That way we follow the GI system along. Aorta, I mentioned if you see any pulsation, see where the aorta comes down? That could be a abdominal aortic aneurysm, which is bad. This is a picture of ascites. If I pushed on that belly right now, it would move like a wave. It's not hard, firm, anything like that. This is an umbilical hernia. GU assessment, most people miss this on skills testing. It's as simple as asking if they're urinating. We're not doing anything more than that. I am not getting all up in there unless I'm putting Foley in. I'm asking questions. Are they urinating okay? Is there any burning, itching? I'm going to assess the symphysis pubis symphysis. Should not be able to palpate after voiding. The nice thing is, and most of you have probably experienced this, but the nice thing is most facilities have the bladder scanners. You don't have to do a straight cat to find out if they have any residual. You can do the bladder scanner, which is nice. Before we would have to straight cat them just to see if there was any urine after voiding. When I am doing anything related to GU, which we don't cover GU in the rest of this program. Oh, yes, we do. Concepts 2, sorry, take that back. Concepts 2, we talk about it. But again, I'm asking questions. Unless I'm putting a Foley in, I'm not really gonna look down there unless that's what they're in for. Urinary elimination, 30 mLs per hour for an adult is normal. 30 mLs an hour, 8 hours, 240. I want what goes in should come out. If I'm doing a strict INO and they're on a Foley, I'm looking to make sure that it's clear. The color is a pale yellow to straw yellow. If their urine is completely clear, they're overhydrated, which can be just as bad as dehydration. Clear urine means they're not excreting any toxins. That's what gives us the yellow color. And if it's dark yellow, dark brown, that means they're not, it's more concentrated because they're dehydrated. When we do homeostasis, we'll get more into detail. Are they continent or are they incontinent? If they're incontinent, we're changing them, keeping them dry because we don't want to cause more problems. The concept of mobility, the movement and engagement in physical activities. Musculoskeletal system will do mobility. Actually, you would have already had mobility prior to this lecture because we're covering it first. But mobility, how do I assess for mobility? If they are ambulatory, I'm assessing their gait. I'm assessing their muscle strength. If they are ambulatory, are they using any assistive devices? The three common musculoskeletal problems are lordosis, kyphosis, and scoliosis. Lordosis is an increased lumbar curvature inward, where kyphosis is more that hunchback, and scoliosis is more like an S. Those of you old enough, you probably remember going to the nurse's office and then she would run her hand down your back, making sure that your spine is aligned. As we get older, we don't necessarily shrink, our spine curves more, which that's what causes us to lose more inches. Other things you're going to do for musculoskeletal, you're going to look at the joints, looking at any contractures, any swelling at the joints, rheumatoid arthritis, regular arthritis, looking at the skin, the characteristics, any swelling. Do we need to get splints and braces? Palpation of the joint area, looking at each one of the areas. If they're not in for that and they're not having any problems, that's not one we put a lot of focus on, but you still need to know it. Range of motion, you have your active, which means they can do it themselves. Passive range of motion is when we provide the movement. We never go past the point of resistance or pain. If you are doing range of motion on a joint, you don't want to force it. That's not something that we do. Measures with the gynometer, if abnormality is present, that's going to be physical therapy is going to do that, unless you're working with physical therapy. Motor, muscle testing specific for each joint. I want to know, assess motion and expected range. If they just had a knee replacement, you don't expect them to bend their knee 90 degrees an hour post-op. Muscle strength graded on 0 to 5. 5 is movement against gravity and resistance. 0 is no movement at all. You would want to assess them symmetrically. You're going to grab both hands, hold their arms up. Can they hold it up? Can they push against you? Gait, heel to toe balance. Ataxia is lack of coordination and instability. Safety, are they using any assistive devices? Do they use any braces, any splints? What is their mental status? In some facilities, side rails are not allowed. Most of the hospitals still allow the 2 up, but some of the rehabs around do not want any side rails up, which I have a hard time with because the top rails are used for mobility to help them move and turn and reposition, but they are considered restraints in some settings. You want to know what your facility allows. Risks for fall, you're going to do a fall risk assessment on your patients. Everyone gets a risk assessment done, and then you determine if they need to be placed on falls. Most places have the non-skid socks, maybe a bracelet. You want to follow your policy when it comes to when you're working. Medications, patients concerned about safety are the medications causing them to get lightheaded, orthostatic hypotension, anything like that. Concept of infection control, the activities used to minimize the spread of microorganisms which cause disease. Infection control is a very large concept because it encompasses hand washing, microorganisms, burns, wounds, surgical incisions, anything that's going to put someone at risk for infection. Skin, we're going to do a full skin assessment. One of the things that Medicare does not cover anymore, if the patient develops a wound while in the hospital. If they come in and they had it and nobody documented it within the first 24 hours, Medicare assumes it happened in your facility, and then Medicare no longer will pay for that visit or the care that led up to it. So you want to make sure you're doing a thorough skin assessment, especially on your older population. Skin is our largest organ, but sometimes little skin issues can cause lots of issues if they're not assessed properly. You're looking at the color of the skin, the temperature, turgor, which is the skin elasticity. When you're doing skin turgor on an older adult, you don't want to grab their hand, because their hand, the elasticity in their hand is very decreased. So you want to grab like closer to the chest, like their sternum, and check skin turgor there. It is not 100% accurate because well, I'm always dehydrated, but if I pull my skin up right now, it'll stay up, but I'm probably dehydrated right now. It does indicate hydration status, and it puts them at higher risk for skin breakdown. With skin, your patients are going to be assessed with the Braden scale. The higher the number, the least the risk they are. You're assessed on 6 different areas: sensory, moisture, nutrition, friction and shear, a couple other things. The higher the number, the lesser the risk. Other things with skin: know your terms. We are a nursing school, so know your terms. Cyanosis is blue. They're not getting enough oxygen to their tissues. Jaundice is yellow. That usually means there's something going on with the liver. Erythema is redness. Eczema and dermatitis are complications of the skin. Melanomas, when we're assessing melanomas, we do ABCD, asymmetry, border, irregularities, color, anything changes, and then diameter greater than 6. That doesn't mean it is cancer, but those are signs that it's leading toward that, and especially if it's changed. So this is just a different picture of the ABCDs. Palpate the skin. You're going to feel the temperature of the skin, check for any moisture, texture, thickness, any edema, checking for mobility and turgor. This is a picture of cyanosis. It's hard to see, but you can kind of see how the toes are a little purple and the side of the foot's purple. So that's cyanosis. They're not getting enough oxygen to the tips of their toes or the tips of their fingers. That means tissue perfusion and oxygenation is affected. Purpura is hemorrhagic disease that produces ecchymosis and petechiae. Jaundice, that would be a liver problem. Petechiae, little red dots. Skin assessment, these are just the different types of skin assessment. When we do we do a, I don't think we do infection control. I have to think about that. We'll do wounds later in the course, but we're not doing sterile wounds. So I don't really think I go over it too detailed. But understanding there are different things. So it's not just a wound or a laceration. There's masculo, papulal, vesicle, pustulal, wheal, plaque, buildup, fissure, scale, scar, ulcer, atrophy, and excoriation. So please review them. While I'm not reading them all, you have them, so please review them. Staging of ulcers. Pressure ulcers are different than wounds. Pressure ulcers are different than surgical wounds. Pressure ulcers happen because of pressure. They usually happen at bony prominences. Your stage 1, there's no break in the skin. It is red. It used to be blanchable versus non-blanchable. It's just red, but it'll go away once you remove the pressure. This is why it's important we turn and reposition our clients frequently. A stage 2 is a break or a blister, a break in the epidermis or a blister. Our skin, we have epidermis, then dermis, then subcutaneous tissue. The stage 2 is a break in the epidermis or a blister, because the blister has now stretched, that is the epidermis. Stage 3 is a break in the epidermis, the dermis, down into some of the subcutaneous tissue. And stage 4 can be all the way down to the structure of the bone. So it's the epidermis, the dermis, subcutaneous tissue. When they get to a stage 4, usually it's through the nerve endings. The pain is not as much as it would be with a 2 and a 3. Braden scale, again, the least risk, the higher the number, the least risk. It assesses sensory perception, moisture, activity, mobility, nutrition, friction, and shear. Friction and shear, if they're sliding up and down in the bed, that's why we should use a draw sheet. If they're incontinent, we're changing them frequently. Nutrition, we have to increase their nutrition, specifically protein. If they have a wound, we could do everything right in the world. We could turn them every hour. We could prop them up. We could make sure they're dry, and they still could have a breakdown because if their nutrition's not up to par, the skin needs that. The skin also needs hydration. An older adult does not need a bath every day. With the older adults, we decrease the sebaceous glands, so then they don't have the oils on the skin to keep them healthy. They don't need a bath every day. Braden scale, so this is just a different picture of the pressure ulcers to prevent them. Movement, repositioning, checking for moisture, when we are pulling them using draw sheets. Inspect and palpate the nails, looking for any clubbing, anything like that. Female reproductive, unless they're coming in for female reproductive problems, we typically don't assess the breast or the vagina, unless that's why they're there. But questions we still want to ask: age of menses, any current patterns, are they in menopause? Because that's going to change some things. Breast self-exam, we do want to talk to them. Do they do the breast self-exam? It should be monthly after menstruation. Any drainage from the nipples, any indurations or dimpling. Are they of age where they need the mammograms? Are they getting the mammograms? Do they have any pain in their breast? If you are working post-OB or postpartum, obviously that assessment's going to change a little bit because we're going to do more detail. But a med-surg floor, I'm not assessing unless that's why they're coming. If they're having or had a mastectomy, yes, my assessment changes. Same thing with the males. I'm not doing any kind of assessments unless that's why they're there. So this just talks about the breast self-exam, the female genitalia. If you're working somewhere where you're doing like testing, gynecological testing, then yes, you would inspect all this. But if they're coming in for something unrelated, I don't need to see it. Same thing with the men. Palpate, inspect and palpate the penis if they have any drainage, anything, if that's what they come in for. If I'm putting a Foley in, obviously, yes, I'm checking those areas. If they have BPH, which is benign prostatic hypertrophy, inserting the Foley might be a little difficult. So we want to ask that. Do they have any problems voiding? Do they have problems starting and stopping their stream? Reproductive, are they doing testicular self-exams? I'm not doing it for them unless that's why they're there. Uncircumcised versus circumcised. If they're uncircumcised, you do want to pull the foreskin back, clean it properly, retract the foreskin back over. You don't want to leave it retracted. That can actually cause more complications. You're going to start seeing more and more people uncircumcised because a lot of people have stopped doing it with their children. They feel it's too painful, so they've stopped doing it for whatever reason. Anus, rectum, and prostate exam. Again, if they're coming in with hemorrhoids, of course, I'm looking. If they're not coming in, I'm not looking. I'm looking at their area just to make sure it's intact, no bleeding, no pressure ulcers or anything, but I'm not doing a prostate or rectum exam unless I have to. Finalize. What do we do? Our biggest thing is determining what type of physical assessment we have to do. The physical part is physically touching them. If we're doing a comprehensive assessment, I'm doing the interview, I'm asking all those important questions before I even do the physical assessment. During the physical assessment, I'm going to assess, are they alert and oriented? Remember, they must consent to this. You cannot force them to do a physical exam. Hi, my name's Amy. I'm going to be your nurse today. Can you tell me your name and date of birth? I use the acronym WIPE. W, wash your hands. Yes, I wash my hands. I is introduce self and ID the patient. We usually use name and date of birth or medical record number. If you're long-term care, you might use their picture. P is for provide privacy. Everyone deserves to have privacy. If you're in a semi-private room, pull the curtain. If you're in a private room, shut the door. That way somebody knows you're doing something, they don't just come walking in. And then E is explain the procedure. If you do those first 4 things, you do 4 things on our checklist. Then you're going to assess them. Ask for pain. If they're having pain, we need to address the pain. If they're not having pain, then I can move on. Ask about allergies, specifically latex. If you're working somewhere where you still have latex material or we're getting ready to do a procedure, I want to make sure I ask all the questions before I touch them. Then once I get into the systems, if they're answering me, I've already assessed their level of consciousness. If they are ambulating, I've already assessed their musculoskeletal system. Some of the systems overlap. You don't necessarily have to do head to toe. If they're complaining of shortness of breath, that's where I'm going to assess first. This is just an idea of how to do it. The level of consciousness, orientation, pain level, PERLA. If you find that PERLA, they're not PERLA, which means one of those things are not, you can't say no PERLA, it's PERLA or you identify what is wrong. Maybe their pupils aren't equal, maybe they're sluggish, then it's not PERLA. So you have to make sure you understand the terminology and how to use it. Anterior lung sounds, and notice I don't have posterior lung sounds here. Heart sounds, bowel sounds, skin, radial pulse, upper extremities. Now I might check their head, their neck, their throat, their eyes, the HEENT, head, ears, eyes, nose, throat. If they're not in for that, I'm not really assessing that. So these are those things that you must do with everybody. And then you add on based on what is abnormal. I hope that makes sense. I'm going to put up an activity that I want you to do, and then we'll talk in class. I think that's it. Yep, that is all, and I will see you in class. Please write down lots of notes and questions, and don't hesitate to ask questions.